Good morning, everyone. I am Michelle Knight, Project Aware Grant Manager for the Utah State Board of Education, and welcome to our Safe and Healthy Schools webinar series. There are a few items of business before we begin. For those who cannot participate today, a recording will be posted to our Safe and Healthy Schools events and trainings page. One relicensure point per hour is available for participants who complete the required questionnaire. The link to the questionnaire will also be posted on the events and trainings page for 1 month from today. We ask that you please remember virtual meeting etiquette and keep your microphones muted. We look forward to having you join us for our future webinars. The topic for April is social and emotional learning and will be held at 3 p.m. on Tuesday, April 20th. I'll now turn the time over to Ashley Postello for an introduction.
Hello, good morning, and thank you for joining us today. My name is Ashley Postello. I am a project administrator with Safe UT at the Huntsman Mental Health Institute, formerly known as UNI. There will be a question and answer portion at the end of the presentation. At that time, you may submit your questions in the chat box, and I will be assisting with the Q&A portion. Back to you, Michelle.
Thanks, Ashley. Since 2003, Ms. Hertz has worked for the Center for Disease Control and Prevention as a lead health scientist in the National Center for Injury Prevention and Control and in the Division of Adolescent and School Health, known as DASH. She is currently a senior behavioral scientist in DASH, focusing on promoting mental health and preventing substance use and violence in school settings. Previously, she led the evaluation of an observational cohort study of medication-assisted treatment, the program evaluation of the core state violence and injury prevention program, and the implementation of the STRIVE program, known as Striving to Prevent Youth Violence Everywhere. Prior to her work at the CDC, Ms. Hertz was the Associate Director of Violence Prevention Programs at Harvard School of Public Health and a school counselor in Washington, D.C. public schools. Ms. Hertz received her BA in psychology from Emory University and a master's degree in psychology from the University of Pennsylvania. We are so grateful to have her here. Without further ado, please welcome Marcy Hertz.
Thank you. Thank you, Michelle and Ashley. And thank you all so much for joining us here. I guess it's this morning for you all. It's this afternoon for me, but I know you all are super busy. And as Michelle just said, I started off my career as a school counselor. So any opportunity I have to talk to folks like yourselves who are on the front lines, working with our students, doing the hard work, I jump at the chance. And so I'm grateful for the opportunity at the end of the presentation to take questions from you all, but also to get your thoughts and feedback on what I've shared, whether it resonates with you or the kinds of things that you're hearing on the ground. There's lots of benefits to being at CDC, but one of the downsides is obviously we're a step removed. So I really rely upon presentations like this to get a sense of what is happening on the ground. So appreciate if everybody takes advantage of that opportunity at the end of the presentation. Okay, so let me just share my screen now so we can get started. Can everybody see? Okay, I'm going to assume everyone can see, and if not, somebody yell or put a comment in the chat. So I'm not going to introduce myself any further than has already been noted, but this presentation is going to focus on mental health and trauma and resilience. Here's an overview of what I'm going to present this morning. First, I'm going to tell you a little bit about the division that I work at CDC, the Division of Adolescent and School Health, or DASH. Present a little bit of the data about what the status of child and adolescent mental health was before COVID-19 hit. I think that's important foundational information to provide, and I'll talk about the connection between that and the impact of COVID. The potential mental health impacts of COVID, and actually we have some preliminary data now about the impact of COVID on child and adolescent mental health. The role of schools in promoting mental health and resilience. Some examples from the field, from the state and local levels. I've got 2 slides with some resources on them. And then, as I said, hopefully plenty of times for questions and comments from you all. It would be nice if it would advance. There we go. Okay, so as I said, I'm going to share a little bit about the Division of Adolescent and School Health where I work at CDC. So the focus here is really not just on the absence of disease, but in promoting health and well-being. So this is what our mission statement is: a future where all youth in the US are equipped with the knowledge, skills, and resources for a healthy adolescence and adulthood. And I think this is really important as we think about mental health, because some people equate mental health with the absence of mental illness, right? So it's the absence of stress or depression. And that's not really the lens that we try to focus on, but we try to focus on kids hitting those developmental and emotional milestones and have the coping skills to be able to handle whatever problems and challenges come their way, and to resolve those challenges in healthy ways. So this is our program model. We are unique at CDC. You might say, I didn't know there was a group at CDC that focused on schools and mental health. Yes, there are actually two of us, the Division of Adolescent and School Health, and then our Healthy Schools branch. We are unique at CDC, and we're unique because we directly fund education agencies as opposed to health departments. So my division directly funds local education agencies, and then our sister branch that I mentioned directly funds state education agencies. We're currently funding 28 local education agencies, and this is the model that we fund the local education agencies to implement. And the hallmark or the foundation of the model is really that person that you see in the middle, the health and wellness coordinator that sits at the district level. The bulk of our funding has historically focused more on sexual health related behaviors. And I'll talk a minute about how we've used this model to address mental health. But it's very similar. The model now focuses on the health and wellness coordinator, helping schools select a quality health education curricula and implement and evaluate it. Linking to services. So these could be school-based services, or these could be services off-site, but it's important that these are youth-friendly and culturally appropriate services. And our sites have done lots of really innovative things, having young people actually rate and review and compile guides to youth-friendly services to ensure that they're not just an adult's perception of youth-friendly, right, but the youth's perception of youth-friendly. And then the third piece are safe and supportive learning environments. And here is a significant portion goes to not just classroom management and school connectedness activities, but also community and family outreach activities. So with this approach, we're able to reach about 2 million students a year at a cost at less than $10 per student. And although the bulk of our funding, as I mentioned, has historically focused on reducing sexual risk behaviors, our evaluation actually showed decreases in all those risk behaviors that you can see on the far right of your screen. So sexual risk behaviors, substance misuse, this includes both misuse of prescription drugs as well as illegal drugs, mental health and suicide, and violence victimization. So we had this comprehensive model already being implemented in 28 school districts. When we were able to leverage this model to use CARES Act funding to implement a model very similar to this to promote mental health and well-being in school districts. So 22 out of our 28 districts applied for this funding and received it. And similar to this model, it funds someone at the district level to coordinate mental health and well-being activities, and to implement the linkage to services, again, school-based or off-site, and safe supportive environments. The only difference is that quality health education piece and this supplemental funding, instead of focusing on health education for this 1 year funding, the component was staff well-being and capacity. So providing professional development in staff to either address their own well-being and or to help them support the emotional well-being of students. So as I mentioned at the outset, I'm going to spend just a minute setting the foundation of what youth mental health was like prior to COVID arriving on the scene. And the spoiler alert is that it was not good. It was already poor and deteriorating before the COVID-19 pandemic hit. So some of you might be familiar with this Adverse Childhood Experiences, or ACEs study. So this is a study we use as the foundation for a lot of our work at CDC. It was a study that CDC conducted in partnership with the Kaiser Permanente folks in San Diego, California. And what they did was survey over 17,000 adults who were just sitting in the Kaiser waiting room waiting for their appointments. And they asked them retrospectively to report on these 3 types of experiences that you see on your screen, these 3 types of abuse, household challenges, and neglect that they experienced before they turned 18 years of age. And again, this is not a really high risk population because these are folks who have health insurance, and therefore they or someone in their family have employment that offers health insurance, and they showed up to their appointment. And what they found was really surprising to a lot of people. They found that more than half of the people in the survey reported at least one of these adverse childhood experiences, and more than a fourth of them reported 2 or more of these adverse childhood experiences. I will say in more recent work, we've been exploring changing what constitutes an adverse childhood experience. For example, adding experiences with bullying or racial discrimination, etc. And some more recent studies have captured that information as well. You might wonder if this data changes if you ask people to report current experiences as opposed to retrospectively. And the answer is it really doesn't change a whole heck of a lot. The National Study of Children's Health, which asked parents about their children's current experiences, mainly with those household challenges, not with abuse and neglect, found really similar data that about 45% of parents said that their child had experienced at least one of those household challenges, and they did not include divorce in their study, and that 1 in 10 had experienced 2 or more of these household related challenges. And then they also found significant disparities by race and ethnicity, with 61% of Black parents reporting that their child had experienced 1 or more of these adverse childhood experiences, 51% of Hispanic parents saying their kids had experienced 1 or more, and 40%, which is still a very significant percentage of white non-Hispanic parents saying that their child had experienced 1 or more of these adverse childhood experiences. So why did all that matter? Why do adverse childhood experiences matter? They matter both in the short term and they matter in the long term, and not just for impacts on mental health. So what this shows in a graphic depiction here is the ACE score, which is that light gray circle. That's the number of those adverse events that I showed you on the prior slide that people reported. And what you see are those tiny colored circles that get larger as the number of adverse childhood experiences increase. And you can see what those colored circles represent are physical and mental health conditions. You see obesity, depression, stroke, lack of physical activity, etc. And what you see is as the number of adverse childhood experiences increases, so too do the size of those circles. So too does the likelihood of experiencing, for example, alcoholism or stroke. And what I've drawn your attention to in those green circles, which are the largest circles, are suicide attempts. So you can see a direct correlation between experiencing adverse childhood events and then subsequent suicide attempts in adulthood. So this is data from a survey that our division collects, the Youth Risk Behavior Survey. It's administered to kids in both public and private schools in grades 9 through 12 every other year, and gives nationally representative data as well as state-specific data, but this is nationally representative data. And what you can see here, this is in 2019 before COVID. What you can see here is for every single mental health related indicator that we track, the trend over the prior 12 years has been moving in the wrong direction. So adolescent mental health has been deteriorating for all of these measures: sadness and hopelessness, considering attempting suicide, making a suicide plan, and attempting suicide over the past 10 years. And the only indicator that did not deteriorate, just stayed the same. It didn't change significantly at all. And that's injured in a suicide attempt that required treatment by a doctor or by a nurse. So one of the predictors of how adolescents, or really anybody, is going to be able to handle the COVID-19 pandemic and the host of factors and isolation and things that went along with that is what their mental health was like before COVID-19, which is why I presented the foundational information about ACEs and the YRBS data. And this is some more YRBS data just highlighting that youth who experience any one of these risks are more likely to experience multiple risks. So for example, what you see in the center of your screen is violence victimization. So 24% of youth who said they experienced some type of violence victimization, and this is from our youth risk behavior survey. So the violence victimization are things related to bullying or sexual violence victimization or dating violence victimization. So 24% of people who said they were victims of violence also reported one of those poor mental health related indicators that I just showed you. And then similarly, 13% of youth who reported high risk substance use, that's use of illicit substances or misuse of prescription drugs, also reported poor mental health. And then finally, you see just over 17% of youth who reported those poor mental health indicators also reported engaging in sexual risk behaviors, such as having 4 or more sexual partners or engaging in unsafe sex. So despite all of these poor mental health related outcomes, unfortunately, there's still a gap between the need for services and receipt of services. And what you see here is data from 2018 from the Substance Use Mental Health Services Administration. And I just want to point out that 3.4 million youth and adolescents received, and this is probably not a surprise to you all, received mental health services in education settings. This was exceeded only in recent years in 2016 by specialty mental health settings. The pluses in the shapes are reflective of a significant increase or change from the prior year. And I really think this graph, while important before COVID, takes on added importance when we consider what happened last spring, which were widespread school closures last spring. About 93% of households reported school-age kids were learning virtually. So we don't really know what happened to those students during virtual learning. And I know in some school districts in Utah, some of you might still be engaged in virtual learning. So we don't know the degree to which those students who were receiving school-based mental health services were still able to receive them. And we know that those who were receiving school-based health services were those in greatest need. So they were students more likely to be students of color, and they were also more likely to be students who did not have health insurance, who were receiving public health insurance. So again, it's unclear what happened to those folks. Again, this is additional data from SAMHSA, and I'll point out that the bars on the far left and the far right, so the red and the bluish gray ones, are the ones that depict youth and adolescents, ages 12 to 17. The darker color, which is on the bottom of those bars, are the youth who actually received treatment. Again, just emphasizing the gap here. So 90% of the kids with a substance use disorder did not receive treatment in the 12 months prior to the survey. And 59% of youth with a major depressive episode, which equaled 3.5 million kids, did not receive treatment for that major depressive episode in the past year. So I don't want to convey all doom and gloom. As you all know, I'm preaching to the choir a little bit here. There is a whole heck of a lot that schools and those who partner with schools can do to help youth and to promote mental well-being and resilience and recovering from prior traumas and from COVID-19 related traumas. So what I'm showing on the screen are some potential reactions of children and adolescents to all sorts of traumas. And for many adolescents, COVID-19 represented just another trauma layered on top of some of those adverse childhood experiences and the mental health challenges that I already pointed out. But what I wanted to highlight here is that a lot of these directly impact their ability to learn and focus. I know that the primary job of schools is to educate students, right? But all of these types of traumas interfere with kids' ability to stay on task and to retain information. Reactions to trauma include difficulty concentrating, worry, anxiety, fear, irritability, acting out behaviors, which often result in punitive consequences, which can further exacerbate those traumas, eating and sleeping changes, depression, and post-traumatic stress disorder. And the likelihood of any adolescent who's experienced any of these adverse childhood experiences.
That's effective, right? It's saying these words can get you closer or farther.
I'm sorry, I was hearing somebody else. I don't know if somebody else was as well, or maybe I'm just getting some feedback. So the likelihood of adolescents experiencing any of these symptoms or the degree or extent to which they experience them depends upon a whole host of other factors, including what their mental health was like prior to the trauma, as well as their age, hours spent watching media coverage if there was a particular trauma or event, and their social and economic supports. I did want to highlight some recently released data from colleagues at CDC. We conducted surveys of parents of kids ages 5 to 12. We also conducted another survey directly of adolescents ages 13 to 19. We conducted the survey in October, November of 2020, and we asked them about their experiences related to COVID and mental health and other well-being related indicators. The data I'm going to share with you right now is specific to parent report and of their child ages 5 to 12. The adolescent data is still under analysis. But what we found is that parents of color were more likely to report that their children were receiving virtual learning as opposed to being either 100% in person or in some kind of hybrid or combined model where they attended school a few days a week or on 1 week and off 1 week. They also found that child's mental and emotional health worsened during the pandemic, and those in virtual learning experienced decreased physical activity, time outside, time with friends in person, and time with friends virtually compared to those who were learning in person. And in terms of the breakdown of virtual instruction by race, ethnicity, as I mentioned, 66% of Hispanic parents reported their kids were in virtual only instruction. And 55% of Black parents reported their kids were in virtual only instruction compared to 32% of white young people. As I mentioned, our adolescent data is currently under analysis, but I expect the findings will be very similar. In fact, findings from other countries, for example, there was an Australian longitudinal study looking at adolescents that was in the field before the COVID-19 pandemic, and they collected data during the pandemic as well. And they found similar data to what I just shared from the parent survey: increases in anxiety, increases in depressive symptoms, and significant decreases among adolescents in life satisfaction pre-pandemic compared to during the pandemic. Interestingly, they found that the negative mental health related outcomes were predicted by COVID-19 related worries, online learning difficulties. So whether they didn't retain the information, they had poor internet connection or accessibility, those were those types of online learning difficulties, and increased conflict with parents. They did find that these negative mental health impacts were buffered by adherence to stay-at-home orders. And I'm going to talk about that in a little bit, about self-efficacy and your ability to feel like you have control over the situation, which I think might have been what was at play there, and feeling socially connected. Feeling socially connected and adhering to stay-at-home orders actually buffered or protected them from those negative mental health effects. And then similarly, a Chinese study, which was conducted in an area that did not experience a high prevalence of COVID, found similar results 2 weeks after kids returned to in-person learning, that there were significant increases in suicide-related ideation, plans, and attempts. And I want to note for some families that the time of school closures, whether that was the spring or it included this this fall and part of this winter might have been a time of increased family connectedness. But for many families, increased time at home was not necessarily a good thing. For many young people, home was not a safe place. We've heard anecdotal data and some emergency department data has reflected increases in child abuse and neglect and increases in suicide related behaviors among US youth as well. So what can be done to promote resiliency in the face of all this? The first thing is to promote a sense of safety. So I think all of this folks are fairly well familiar with now, but sharing what answers to young people's questions, giving accurate information, not conveying more information than young people are asking for, but talking about ways that you as a school staff member or as a parent are working to keep them safe and ways they can keep themselves safe. Secondly, promoting calm yourself. There was a study that CDC did related to H1N1 flu pandemic, and they found that parents' level of anxiety and post-traumatic stress was directly associated with their child or adolescent's level of anxiety or stress. So parents and adults who remain calm are able to promote that in the young people that they work with and their family members. Third, promoting a sense of self and collective efficacy. So what can you do to keep yourself safe? A lot of anxiety comes from a sense of unpredictability and loss of control. So saying if you wear your mask, you are better able to keep yourself safe. If you wash your hands, I know we saw at the outset of the pandemic a lot of making masks for other people and providing food for first responders. All those things are really helpful in promoting resiliency among children, adolescents, and adults, honestly, in the wake of traumas or disasters. And I should say this is not only relevant to something like COVID, but they found this in the wake of Hurricane Katrina and school shootings, et cetera. These are five concepts that really stand the test of time in responding to different types of traumas. And then promoting connectedness. And I'm going to talk a lot more about connectedness. It's one of my favorite things to talk about, connectedness to family and school here. And then fifth, promote hope. This is not going to last forever. It will end. It's very important to keep it realistic, though, and not set unreasonable expectations. So as I mentioned, I love to talk about connectedness because I think it's kind of magical. It's what we call a high leverage solution or approach to all different types of high risk behaviors here. So as I mentioned, CDC and our funding to our school districts focuses primarily on reducing health risk behaviors related to sexual risk. But we found that increasing school and family connectedness, and we do this through mentoring programs, we do this through helping fund professional development for staff about classroom management techniques and reaching out and connecting with families and other community partners, that kids who have strong connections to their school, who think their school is fair, who think there's adults at their school who care about them, non-parents who care about them, two adults who are not their parents, who care about them and are invested in them. Kids who have those connections are less likely to engage in all those kinds of risk behaviors that you see in that arrow. They're less likely to experience physical violence, to report having multiple sexual partners, to report misusing prescription drugs, to report those mental health related outcomes I talked about, to report sexually transmitted disease infection, and to report an illicit drug. So feeling connected to family and to school is critically important. So how can you do that? So these are some ways to do it virtually. I know that most of you in Utah are back in school, but I left this slide in because I think if there's any silver lining of the pandemic, I think that some of those creative and innovative strategies that I know that you all put in place, perhaps in the spring of last year, have some nuggets that can continue. And one of those are the daily check-ins to the extent you can with the kiddos you work with. So how are they feeling? Not just did you complete the assignment, how are things going? How are things going for you? Sometimes that can be done through an app if you're working with younger students. I know some of you have that for tracking classroom behavior, for example, but there's ways to use those apps to put a smiley face or a straight face or a sad face. And then for the older kids, there are check-in forms like I have on the screen here to check in with students and their families to see how they're doing. The second piece is to tie social emotional learning skills to management of COVID. There's some great resources available from CASEL, which is the Collaborative for Academic, Social, and Emotional Learning. I always have to rack my brain for what CASEL stands for. They've got a lot of great resources, many of which are now free. I will say I've seen a lot of great innovations. A lot of the social emotional learning resources were developed for use in elementary schools, but I've seen a lot of great and innovative ways that local schools, school districts, and states have been pivoting to use those materials for older students in middle and high school as well. And a lot of those related activities in terms of teaching mindfulness and empathy and awareness are things that are going to serve the students well, not only in wake of COVID, but just in focusing on learning and re-engaging as well. And then keeping up school routines and rituals to the extent that is possible, whether you're still virtual learning, you're trying to recapture lost learning, which I know is a significant barrier here. And then lastly, I always put in a plug for not forgetting about staff well-being. Again, I'm probably preaching to the choir here, but I know everybody is so invested in student well-being, but there's no way that that staff can adequately help the students that they work with if their emotional well-being is not addressed, whether that's through professional development related activities, and we've seen a lot of those occurred and hopefully will continue to occur after COVID to support stress reduction, mindfulness activities for staff, and then teaching them different ways in professional development to help them recognize kiddos who might be in need of assistance. So I really love this new work that's coming out of Boston. There's a pediatrician there named Bob Segi, and he's like, why are we only focusing on these adverse childhood experiences? Well, it's great that we focus on preventing them. Can we learn a little bit more about what kinds of positive things that we could do to help protect kids who have experienced some of these adverse childhood experiences? So what he did was partner with the state of Wisconsin, and he did something similar to that Kaiser Permanente ACE study I mentioned at the outset. They asked adults in Wisconsin about their positive childhood experiences, so those positive experiences that they had before the age of 18. And many of you can probably guess what types of positive experiences they asked people about. They asked if when they were young, were they able to talk with someone in their family about how they were feeling, if they were feeling upset, if they felt like there was someone in their family who stood by them during difficult times, if they had regular family traditions or rituals that they enjoyed participating in, if they felt a sense of belonging or connectedness. This was in high school. They asked about a sense of belonging or connectedness to high school. They asked if when they were growing up, they felt a sense of connection and felt like they had friends they were connected to and could rely upon. They asked if they had two of those non-family, non-parent related adults that took a genuine interest in their interests and well-being. And then the seventh thing they asked about was if they felt safe and protected from an adult in their home. And then you see the results here on your screen, that those adults who reported that when they were kids, they had 6 or 7 of those positive childhood experiences, they had a 72% lower odds of reporting depression or poor mental health compared to those who reported 0 or 2 of these positive experiences. So these positive experiences also buffered or protected adults, even those who experienced those adverse childhood experiences. And another national study of parents asking about their children's exposure to adverse experiences and these positive experiences founded that resilience, which they defined in the study, is staying calm and in control when faced with the challenge, those children who were ages 6 to 17 who reported resilience eliminated the impact of those adverse childhood experiences. So this report from Wisconsin has been validated with other data as well. They also found higher rates of school engagement among kids with adverse experiences who demonstrated positive experiences. And there are several ways that schools can build resilience, including through social emotional learning, which I'm going to get to in just a moment. So this is from a report at the bottom of the screen, which if you haven't seen, I highly suggest you take a look at, Advancing Comprehensive School Mental Health Guidance from the Field. And these are core features of comprehensive school mental health systems. I should also add that DASH partnered with the American Academy of Pediatrics to interview 7 school districts about how they were able to implement these 8 components. And I believe that report is up on their website if you want some more case data about how places have been able to do these things, because I think folks know in theory that these are all important components of a comprehensive mental health approach in schools, but in a lot of cases, it's easier said than done. The first foundational piece, I'm not going to go through all of these, are well-trained educators and specialized instructional support personnel who are able to work up to the top level of their credentialing. So they're able to spend time with students delivering the kinds of services and making referrals and doing all of those things that they were trained to do. It's very important that they also be able to implement number 4, the multi-tiered system of support, which I'm also going to get to on the next slide, so that they can implement activities and programs universally to all the students in a school or a particular grade, and then deliver smaller group activities to students who might be at increased risk, and then some of that more individual level service or refer out for those more individual level services. Mental health screening is something that we've been seeing happen more and more often. I don't know, I'm interested to hear from you all. If you all are doing that more generally, screening kids for mental health, I think this is a great idea if folks have the capacity to do that. It's often hard for folks to be able to screen. Parental permission is certainly a challenge. And then to have folks available to reveal the results of the screen in enough time, and then to have enough services that are youth-friendly and affordable and accessible to refer to for those who screen in need of further service. Now, I just want to highlight a few examples from the field. Again, I'm hoping during our question and answer period, I can hear some more from you all about what you all are doing and seeing in the field. So this is from the Indiana Department of Education. They have a roadmap for SEL re-entry that they developed at the end of last school year, kind of prepping for kids returning to school. And this is a really important, I think, if any silver lining, this is it. Given the individual and collective trauma felt throughout our communities from stay-at-home orders, daily data displayed on illness and death rates, and of course, the closure of most schools, SEL, or social emotional learning, has moved from a nice to do to a must do in preparing for the student and staff return. And I would say on an ongoing basis as well. I think we assume, unlike reading and math, that if we teach them in kindergarten how to get along and play nicely with others, or in elementary school, that we don't need to do it again. And I would just make the case that that's not the case, that it's critically important for students to be exposed to social emotional learning throughout their schooling experience. So here's some examples of local work related to mental health from the local education agencies that I mentioned that DASH funds. So our Houston Department of Education held weekly mental health webinars and launched a mental health hotline, which I believe is still in place. And they trained facilitators in all their campuses in trauma-informed practices. So obviously that helps sustain them, not just in the short term, but obviously down the road, and not just related to COVID, related to all those other broader traumas that I mentioned at the outset. In Albuquerque, they train staff on how to recognize child abuse virtually, and that training has continued. And then in Boston, they provided remote lesson materials on stress reduction and coping, social emotional learning, telemedicine. They had check-in calls. They actually called all students last spring to do wellness related checks. And then I thought this was a great example of youth development and youth empowerment. They already had their peer facilitators. So they used those folks to do workshops on coping and how to support friends. And you see one of the examples from Boston is what's shown on your screen right there. Here are some examples at the state level. As I mentioned, our sister agency, our sister office, the Healthy Schools Unit, and our Chronic Disease Center directly funds the state education agencies. So Iowa actually passed a law related to social emotional learning in 2018, so before COVID hit, requiring school employee training and protocols related to suicide prevention and identification of those ACEs and strategies to mitigate toxic stress, in the words of the legislation. And all Iowa school districts are now required to adopt those protocols and to attend an annual training for staff in grades K through 12. And then I also have an example here from the Illinois Education Association. And IEA trained more than 100 teachers in trauma-sensitive practices in the classroom. They collaborated with Illinois State University and other community-based organizations to launch this training, a learning collaborative to train teachers and mental health clinicians in trauma-sensitive education in 10 different areas throughout the state. They had regional trainings. And then lastly, Washington State, there's that great resource that I put on there. Hopefully you'll all get copies of the slides. If not, feel free to email me and I can share them all about Compassionate Schools, which considers the implementation of a trauma-sensitive infrastructure. That's the document that you have on your screen there. It includes social emotional learning. It includes weaving mindfulness activities throughout the school day and teaching into all subjects. It includes creating a contract with students that provides empowerment of choice of activity, choice of consequence, or choice of exercise. So it's a really great resource that I highly recommend. Again, that Washington State resource there. And then here are a plethora of resources that are really focused on COVID specifically, but related to these social emotional types of learning and mental health promotion and resiliency initiatives that I mentioned. So you see on the left there, the resource from the Collaborative on Academic, Social, and Emotional Learning, or CASEL. This is about implementing SEL, and it has some great tips in terms of partnering with staff, students, families, and communities and examining data. And so you have the link there, an action plan for a successful second semester or third semester or fourth semester, as the case may be. And then you have a document from Los Angeles Unified Schools, which just started in the past few weeks, welcoming back their elementary school students. And they have an entire toolkit on mental wellness. It's not just limited to a virtual environment. They actually had a robust mental health and well-being program beforehand. And I think a lot of the tools and resources in there can be tailored to lots of different school districts and settings. That next document, School Reentry Considerations, that black and yellow document, is from the National Association for School Psychologists and includes a lot of great planning supports for, again, students, families, staff members, and examining the infrastructure needed to be able to conduct those universal types of screenings that I was talking about on the prior slide. So particularly if you're a school mental health professional, I would encourage you to take a look at that document. And then finally, the call that I just hopped off of to get on this call was with Mental Health America. And they have a great, this was a 2020 back to school COVID toolkit, but again, a lot of great resources that have a lot of information that can be personalized. They have space at the top to personalize it to your school district and add your district specific information there. And then here is just a plethora of lots of links and resources. I always feel like it's better to put more out there than less because you never know what's going to resonate with different folks. I'm always asked for CDC updated guidance about COVID. So you've got that link there. We just recently revised it. You may have heard in the news. And then lots of resources about school connectedness and social emotional learning, as well as some great resources from our colleagues at SAMHSA who fund the National Center for Child Traumatic Stress. They've got another resource about addressing race and trauma in the classroom and trauma in school environments as well. The Crisis Counseling Assistance Training Program, again from SAMHSA. And then another CASEL-related resource that I did not highlight on the prior slide. And then finally, some resources specific to teachers about managing emotions during difficult times and during COVID. So in summary, we are really highlighting in all of our recent presentations that we see mental health, and I highlight adolescents because that's who we focus on in DASH, but it's really mental health among children and adolescents as a public health crisis. As I highlighted before, mental health, unfortunately, was already trending in the wrong direction prior to COVID and school closures and loss of connectedness with peers. And so we were already challenged beforehand, and this just added another trauma on top of that. But the good news is we do know where to start. We've got lots of great resources and foundations to build upon. And we know that starting early as we can in K through 12 can save both lives and can save money. Starting now saves lives and money down the line. We know that school connectedness is one of those important levers in preventing not just poor mental health, but those host of negative health risk behaviors I mentioned earlier. And we know that schools can do this work, and we have examples of that as well. I mentioned that American Academy of Pediatrics report where we interviewed 7 school districts and said, hey, how did you manage to stand up a comprehensive school mental health program? And they shared with us some of their tips and tricks and lessons learned along the way. And then finally, as I mentioned, every time I give a talk, I ask what people in the field are doing, and I learn about all the great, cool, and innovative things you all are doing. We know you all need support, so we want to hear about what kinds of support you need. And hopefully, if we're able to provide it, we're happy to lean in and to make connections when we cannot directly provide it. So that is it. That's the conclusion of my presentation, and I will open it up now for questions or comments or thoughts.
Yes, wonderful. Thank you so much, Marcy. We've had a few questions throughout the presentation, but I will start with having access and a copy of her slides and of the PowerPoint. Yes, it is going to be available on our events and trainings webpage, but I will let Shalise explain the details of where you can find it.
Thank you, Ashley. So I'm Shalise Oldroyd, one of the support staff for the Safe and Healthy Schools team at the State Board of Education. And a copy of Marcy's presentation will be available as a link to a PDF for the time that the webinar evaluation and questionnaire for relicensure point and hour are available. So for the month after today, those 2 things will be available on the webpage.
Wonderful. Thank you, Shalise. At the beginning of your presentation, Marcy, you were speaking about the districts that work directly with your CDC program. And we did have, Kristen is actually asking, I believe, if there is a list of those districts possibly.
There is a list of them. I'll go ahead and drop in the chat the link to the list of districts that we fund. Yes.
Wonderful. Thank you. Awesome. Thank you so much, Marcy. The next question we had throughout your presentation was from Jennifer asking, where can we access the results of the parent survey done by the CDC?
I am happy to send you the link to the newly released, it was just released last week. So I will go ahead and pop the link to that parent report in the chat as well.
Wonderful. Next, we have a question from Marianne, and she is asking, was there any additional information about the disparity for the choice for virtual learning?
That is a really, really good question. And unfortunately, we did not ask about that on the baseline survey, but fortunately, it's a longitudinal survey. So we're going back in the field next week. And so we are asking now on the follow-up survey if they had a choice with how they attended school, if they had the option to go back in person and then they just chose not to. So that's a great question. We wish we had asked that on the baseline survey, but unfortunately, we did not think to ask that, but we are going to ask that when we're back in the field next week.
We have another question. How does race affect a student's access to outside mental health services?
Yeah, thank you for the question. I think, we saw some of the data from SAMHSA that Black and Hispanic young people are more likely than white young people to rely solely on school-based mental health services. So I think that's one way it affects their access to outside mental health services. And then I think there's a lack of youth-friendly mental health services. And then when you layer cultural competency into it, I think that also plays into lack of mental health services that are good fits for some young people of color. And then I would also say, and this is not just a concern for young people of color, but for all people, I think there's a lot of stigma still around mental health and mental health services. So I think that's an issue too, that I could have done a whole other presentation on. And I think that some of the campaigns and some of the universal mental health promotion activities are really important in trying to destigmatize mental health and mental health services.
We do not have any other questions at this time, but if you do have a question for Marcy, go ahead and drop it in the chat, please. We still have about 7 minutes.
Or if you have any information, anything you're doing in your school or district that you think is great or innovative and you want to share with me, I would love to hear about it. Did those students who did virtual learning keep their grades up and have large participation? Another great question that would have been awesome for us to ask. I think in the baseline survey, we were trying not to focus on grades. I feel like there were so many factors that schools weren't quite grading the same as they were virtually as in person. So we were a little concerned about what that data would show. But the one about attendance is a big question. We know some kids were kind of lost, right? Never logged in, or if they logged in, they didn't log in very often. So again, hindsight is 2020. Thankfully, we were able to add a question in the spring asking how often they attended school. However, they were supposed to attend it. How often did they show up, or how often did they log on? I will say, when I was working on the CDC COVID response, we have a bunch of response-related surveys in the field that ask teachers and other school staff how much they feel like their kids, their students learned this year as compared to pre-pandemic, and their perception of whether kids were able to focus and other types of learning difficulties. What do I think about students with anxiety doing online learning? It's interesting, right? I think in some cases we've seen that kids who are bullied in school or had social challenges in school are actually doing better online, right? And so I think it's kind of a mixed bag about that. We are looking at anxiety. I'm trying to not foreshadow things that aren't published yet with our adolescent survey. I think in general, the data suggests that kids who are online only as compared to in-person report more stress and anxiety. Kind of going back to that Australian study that I mentioned. I know my own 6th grader was online virtually, except for the past month. And, just Zoom, even though we're high resource, and he was frustrated, right? With the Zoom freezing up, like we all are in work, Zoom freezing up, things not working right, losing track of things. And I think that's borne out in the data that we've been seeing so far too, that kids who are online are more likely to report stress and anxiety compared to those who are in person.
We have a question from Lori. So often parents are telling me they can't get their children in and services are so difficult to access in a timely manner. I guess my question is, do you have any strategies for helping parents and families access mental health more efficiently?
Well, that's what we're talking. I'm with you. You're preaching to the choir. I think it is really hard. And I will say that a lot of the mental health services are not accessible for a variety of reasons. Either you can't get an appointment. If you have insurance, they don't take your insurance, aside from the youth-friendly and ensuring that they're a good match. I think that's why we're trying to scale up the DASH model, honestly, because I think kids are in, most kids are in school. Most kids, there are a small percentage that drop out or don't attend regularly, but most kids are on school. So the extent we can provide them in a school setting, even if it's a community partner coming into the school and providing the service, I think that's an avenue there. And then to provide these universal strategies as much as we can is another option. Something else that we've been working on are partnering with some of the outside organizations such as Boys and Girls Clubs and places like that, community centers and places like that, and trying to provide, partner with them, YMCAs, to provide more services on site. We know some of those community-based schools or the 21st Century Community Learning Centers, I think the U.S. Department of Education funded back in the day, tried to do those types of strategies. So unfortunately, I don't have any magic tips except for partnering with community-based organizations, including universities and graduate programs. I think graduate programs in psychology and social work, those folks have to get clinic hours. They need hours of direct supervision. So you might be able to leverage those folks to be able to get affordable on-site services as much as you can.
Thank you. We have a few commenting here. Tess says, many of my students report that having a 4-day week instead of 5 has helped a lot with their mental health. We have a support saying the 4-day week has helped with teachers as well. We have about 2 minutes left. So our next question is, how can we promote self-compassion among school staff and students? This pandemic is hard.
I think that's really important, and we try to emphasize that. That's why part of the DASH funding, we made a decision to have the third arm in our model is traditionally health education, and we replaced that with staff support, right? And that wasn't just limited to teachers, that was limited to everybody. So whether that's professional development or self-care and resources for teachers, stress reduction related activities, mindfulness, taking the breaks, giving the time off to plan and just focus on yourself. I mean, I think that is critically important for everybody to give everybody else a break, right? And I should say, I think that could go a long way in society in general, not just in school, but in particular in school. And those of you who are on the front lines and trying to perhaps cope with your own families and stressors in addition to your students. I think helping each other, right, being peer supports for each other is also another good resource and option. When it comes to money to get services, what is CC to ensuring that underrepresented get access to mental health providers? So really, we don't directly fund mental health services, because that's traditionally been where SAMHSA, the Substance Abuse Mental Health Services organization, funds. I will say the way we fund our local education agencies, they're required to identify 10 higher needs schools and to work with those higher need schools. And there's specific criteria about data that they have to present that demonstrates that those schools are higher need. So we try to get the bulk of the funding to be directed to underrepresented areas.
All right, Marcy. Well, it is 12 o'clock, so we are going to respect everyone's time today. We want to say thank you for everyone who has joined us, and thank you to Marcy as well.
Thank you so much, everybody. I just put my email address in the chat. If you want to share with me anything that you're doing or get my thoughts on anything, please feel free to email me. Like I said, I really like hearing from the field what's going on and what resonated with you or what seemed not feasible or relevant. It's really helpful for me to help everybody like yourselves in the field. So thank you so much.
Yes, of course. Again, thank you everyone for being here, and enjoy the rest of your day.